Hi, my name is Tawney Palmer. I'm a graduate nursing student at West Texas A&M University. I'm first going to show you the room around me. Okay. I'm going to be demonstrating a head-to-toe assessment on a 29-year-old female patient that's come in for a physical exam. Prior to this, she's completed the general survey. We've gone over her past medical history, her past surgical history, allergies. She doesn't take any medications. I've obtained her vital signs, which were all within normal limits. I've gotten her height and weight, and I've also tested her optic nerve, cranial nerve number 2 with the Snellen and eye chart. She has a visual acuity of 20/20 bilaterally. I've listened to the patient's speech and demeanor, noted that the patient is alert and oriented to person, place, and time. I've washed my hands, and now we're going to go ahead and get started with our head-to-toe assessment. So first, I'm going to start with a general inspection of the head and neck. I'm going to start by taking a look at her scalp, feeling the texture of her hair, making sure the skull feels nice and intact, that there's no bony nodules or lesions I should be concerned about. I'm also assessing the skin for moisture, dryness, and temperature as I go along. I'm going to go ahead and check her temporal pulses bilaterally, making sure they're 2+ and normal. I'm going to go ahead and palpate her frontal sinuses, her maxillary sinuses, making sure there's no tenderness noted. I'm going to go ahead and test cranial nerve number 5, the trigeminal nerve. So just tell me if this feels sharp or dull.
Dull. Sharp. Dull. Sharp. Dull. Sharp.
Okay. While I'm here, I'm going to go ahead and make sure that the eyes and ears look symmetrical and that the nose and mouth are midline. Next, I'm going to go ahead and palpate her temporal mandibular joint. You can open your jaw for me. Perfect. And I should be able to fit about 2 to 3 fingers behind her jaw here. Go ahead and close it and move it side to side. Perfect. And I don't know any difficulty or clicking. So now I'm going to check for hair distribution on her arms, color, making sure there's not any significant moles or nevi or discoloration. I'm going to check the color of the nail beds and the capillary refill. I'm just looking for clubbing of the fingers and the toes. Now we're going to go ahead and move on to the eyes. So first I'm just assessing for pupillary response, checking direct and consensual. So if you'll just look at the wall for me. Looking at direct and consensual, and direct and consensual. So now I'm going to go ahead and test accommodation. So if you'll look at my pen light, back at the wall, and pen light, and back at the wall. And while I'm looking at the eyes, I'm assessing the sclera, the conjunctiva of each eye for any nodules, swelling, making sure that the conjunctiva is nice and pink and there's not any yellowing, signifying any dehydration or liver disease. I'm also inspecting the cornea, the iris, and the lens for opacity. Moving on, I'm going to go ahead and test cranial nerve number 3, 4, and 6, the ocular motor, the trochlear, and the inducents with the 6 fields of gaze. If you'll just follow my pen light, not move your head. Perfect. Just looking for any kind of nystagmus or jerking of the eye. We're going to go ahead and look at the optic disc with the red reflex, looking for any kind of papilledema or any abnormalities. So I'm going to brace my hand against the patient's forehead just for stabilization. Perfect. And on the other side. Perfect. Everything looks great with the eyes. I'm going to go ahead and move on to the ears. So first I'm making sure that they look symmetrical. I'm going to palpate the auricle and the tragus and the mastoid of the ears, making sure there's not any nodules or tenderness. I'm going to go ahead and look at the inside of the ears. So I'm just going to do this by pulling the pinna up and back. And I'm just inspecting the ear canal and the tympanic membrane, making sure it's nice and clear, noting the color, the contour and mobility, and ensuring that there's no signs of redness or bulging, signifying any kind of infection. So now I'm going to go ahead and test cranial nerve number 8, the acoustic. You'll just repeat what I'm saying. 66.
66.
55.
55.
Perfect. So finishing up with the ears, I'm going to go ahead and do the Weber and Rhine test. With the Weber test, I'm going to test for lateralization, ensuring that hearing is even on both sides. So tell me if you feel this evenly.
Yes.
Okay. We'll go ahead and do the Rhine test. So this is testing air to bone conduction, which should be 2 to 1. So let me know when you've quit feeling the vibrations.
Quit feeling them. Quit hearing them.
Perfect. We're going to go ahead and move on to the nose. First, I'm assessing the nares, making sure there's no septal deviation and that it's midline. I'm going to inspect the interior and inferior surfaces of the nose for asymmetry, for any nodules or tenderness. Next, I'm inspecting the nasal mucosa for any deviation, polyps, exudate, or anything. I'm going to test the patency of each nair, so if you'll just take a deep breath in for me. And again. Perfect. So now I'm going to go ahead and test the olfactory nerve, cranial nerve, number 1 on both sides. If you'll close your eyes for me and tell me what you smell.
Alcohol.
And again.
Alcohol.
Perfect. So we're going to go ahead and move on to the mouth. So first I'm just looking at the color of the lips, assessing for ulcerations, cracking. I'm going to have the patient open her mouth and taking a look at the oral mucosa, making sure it's moist and pink. There aren't any ulcers or white patches. I'm inspecting the gingiva for erythema, swelling, any irritation. I'm also looking at the interdental papilla for any ulcerations and noting if any teeth are missing, discolored, abnormally positioned. Next, I'm going to have you lift your tongue for me. Looking at the vascularization under the tongue and that there's no lesions noted. Next, I'm going to test the gag reflex. Perfect. And the patient responds appropriately. That's cranial nerve number 9, the glossopharyngeal nerve. And now I'm going to go ahead and have the patient stick her tongue out for me. Say ah.
Ah.
And the uvula is nice and midline. I'm going to have you, that's testing vagus nerve, cranial nerve number 10. And go ahead and protrude your tongue for me. And that's the hypoglossal nerve, cranial nerve number 12. We're going to finish up with cranial nerve number 7, the facial. If you'll smile and puff out your cheeks. Perfect. And cranial nerve number 11, the spinal accessory. If you'll shrug your shoulders against my hands. Perfect. So moving on, we're going to go to the neck. So first I'm making sure that the trachea is nice and midline. It's not deviating or noting that the patient's having any difficulty breathing. I'm also watching the neck during inspiration for any accessory muscle usage, signifying any respiratory distress. I'm going to go ahead and palpate the patient's thyroid. So I would just stand behind the patient, place both hands on either side of the neck, and ask you to swallow. Perfect. I'm going to go ahead and palpate her lymph nodes. So the preauricle, the postauricle, the submandibular, submental, cervical, postcervical, supraclavicular, and the axillary. I'm checking for any kind of tenderness, enlarged swelling, anything that could be abnormal. While I'm here, I'm going to go ahead and test range of motion and muscle strength of the neck. So if you'll just touch your ear to one side and to the other, look down and look up. Perfect. So we're going to test muscle strength and just to move your head against my hand. And on the other side. Perfect. So I'm gonna go ahead and check for the carotid. So I'm gonna palpate each, making sure they're 2 plus, just one side at a time. Perfect. So I'm gonna go ahead and listen for any carotid bruits or whooshing sounds. So you're gonna take a nice deep breath in, let it out, and hold it, okay? Perfect. And on the other side, deep breath in, let it out, and hold it. Perfect. I'm gonna go ahead and have you turn around. We're gonna move on to the posterior chest. So first I'm just inspecting for any kind of labored breathing, making sure that the chest is rising nice and evenly, watching for any deformities or muscle retractions. I'm going to test chest expansion now by placing both of my hands next to each other. Have me take a nice deep breath in. I'm watching my thumbs rise nice and separate evenly. While I'm back here, I'm going to go ahead and test for any costovertebral angle tenderness over the left and right lungs. So, any tenderness there?
No.
Any there?
No.
I'm going to go ahead and palpate bilaterally for tactile fremitus. You'll just say 99 for me.
99. 99. 99. 99.
Perfect. I'm going to go ahead and percuss over the entire lung field. I'm listening for resonant lung sounds, any kind of dullness that could signify fluid in the lungs, and any hyperresonance, maybe an overexpanded lung like an NCOPD. And I'm just moving down in a ladder-like motion. Perfect. And now checking for diaphragmatic excursion. Take a deep breath in for me and hold it. And we'll just go until we get to the point of dullness. Perfect. And go ahead and do the same thing. Take a deep breath in, let it out, and hold it. Perfect. Then I'd measure between the two areas. And now we're going to go ahead and auscultate her breath sounds, listening for any kind of adventitious breath sounds like wheezing, rhonchi, or crackles. So just take some nice deep breaths for me. I don't hear any adventitious sounds at all. So we're going to go ahead and listen for bronchophony, egophony, and whisper pectorally. So go ahead and say 99 for me.
99. 99. 99.
And say E.
E. E.
Perfect. I'm going to go ahead and have you turn back around. And I'm going to go ahead and talk through the breast and axial exam. So first I would be inspecting the axilla in both sexes, filling the axillary nodes. For women, I would inspect the breasts in 4 views. So arms at side, arms overhead, arms pressed against hips, and then leaning forward. And this is to assess the skin appearance, the size, symmetry, the contour, and nipple characteristics. I would note the color, watching for any redness that could signify inflammation or an infection, looking for masses, dimpling, and comparing it with the other side to assess for visible signs of breast cancer. After inspecting the breast, I would palpate with the patient supine, palpating in a vertical strip pattern in small concentric circles, applying light, medium, and then deep pressure individually. And it would be from the clavicle to the bra line, the mid-sternal line to the posterior axillary line. I'd be noting the consistency of the breast tissue, any tenderness, any nodules. I would then palpate the nipple, noting the elasticity, and moving on to the axilla. While the patient's supine, I will inspect for rashes, irritation, for any infection or unusual pigmentation. So for the left axilla, I would use my right hand, reach towards the apex of the axilla, and placing my fingers directly behind the pectoral muscle, pressing my fingers towards the chest wall and sliding downward, trying to palpate the nodes. And I would note the size, shape, mobility, or any tenderness of any nodules found. I do the same on the right axilla with my left hand. And for a male, the examination of a breast male examination is important, examining the areola for any nodules or masses. I'll palpate the areola and the breast tissue for any hard, irregular, or ulcerating, painless dominant masses that could suggest breast cancer. So since we're finished with the posterior chest, I'm going to move on to the anterior chest. So once again, I'm inspecting the thorax, making sure that there's nice and even chest rise and fall, no labored breathing, no retractory muscle usage, signifying difficulty breathing. I'm inspecting for deformities, muscle retraction, tender areas, or any skin changes. Also want to check the AP diameter to make sure that the patient doesn't have a barrel chest. So now I'm going to go ahead and palpate for any kind of thrills or heaves with the ball of my hand and the pads of my fingers. Also checking for any tenderness or bruising or respiratory expansion. Also checking for emetus once again with the ulnar surface of my hand. And at this point, while I'm here, I'm going to go ahead and palpate for the point of maximum intensity. So I'm going to have you exhale fully, stop breathing for a few seconds. And this patient's fairly thin and in healthy condition, so I can feel it really well. I'm going to go ahead and percuss the anterior lung fields. Once again, listening for those resonant percussion sounds. Perfect. I'm going to go ahead and listen to her breath sounds. So just some nice deep breaths for me. And I'm going to go ahead and listen to the lateral breath sounds as well. Perfect. I'm going to have you lean slightly forward to bring the apex of that heart forward. So I'm going to go ahead and listen for heart sounds. I'm going to listen at the aortic at the right second intercostal space, the pulmonic at the left second intercostal space, Erb's point, left third intercostal space, the tricuspid, lower left sternal border, fourth intercostal space, and the mitral, left fifth intercostal space at the midclavicular line, making sure I'm hearing a strong S1 and S2. Have you continue to lean forward. I'm going to flip the bell of my stethoscope and listen for any kind of murmurs. Perfect. We're going to move on to jugular venous pressure. So I'm going to have you lean back, and the head of the bed's going to be at 30 degrees. Perfect. To check for jugular venous pressure, I'm going to have the patient turn her head slightly towards the right. And while I'm looking for the highest point of the meniscus of the internal jugular pulsation. I'm just looking for the pulsations in the suprasternal notch and identify the highest point of pulsation. And I'm going to take my centimeter ruler, place it vertically on the sternal angle, and make it something flat, like a piece of paper. Put it at the meniscus, measuring straight across. Perfect. We're going to move on to the abdomen. So first I'm just doing a general inspection of the patient's appearance, noting any signs of distress, making sure there's no bruising around the umbilicus or any visible peristalsis or pulsations, looking for masses, scars, striae, noting the skin temperature and the color. So now I'm going to go ahead and auscultate the bowel sounds in all 4 quadrants, listening for presence, any characteristics, or any bruits. Perfect. Her bowel sounds are all normal active. So I have my stethoscope in hand. I'm going to listen to the aorta and the femoral arteries, checking for any kind of whooshing or any bruits. No bruits were noted. So I'm going to go ahead and continue with my abdominal assessment. First, I'm going to go ahead and percuss over the entire abdomen, lightly and systemically, listening for tympany, as well as dullness over any organs. Perfect. And I'm going to go ahead and measure the liver span. So I'm going to start at right at the umbilicus, percuss superiorly until dullness is indicated at the bottom of that liver border. And then I'd go from the midclavicular line just under the nipple and percuss inferiorly until dullness denotes the upper liver border. Perfect. And I'd measure that. I'm going to go ahead and move over to the spleen, percussing for splenic dullness. And now moving on to palpitation, we're going to start with light palpitation over the entire abdomen. Once again, checking for the patient grimacing, not noting any signs of tenderness, and feeling for masses. We're going to go on to deep palpitation. So I'm going to place my left hand under the patient's back. Have the patient take a nice deep breath in and relax. Palpating for the liver edge. And hers is nice and smooth. Perfect. And I'm going to place my left hand once again under her back. And I'm going to be palpating for the spleen. One more time. Perfect. And now moving down to the kidney. Left kidney and right kidney. Once again, checking for any kind of tenderness that could signify any infection. Right, so we're going to go ahead and move on to the lower extremities while I have the patient supine. I'm going to have you raise one leg at a time, and we're going to dorsiflex the foot, checking for any kind of pain or herniated disc in the back. Any pain? Yeah. Okay. We're going to move on to range of motion of the hip. So we're going to test for flexion, extension, abduction, adduction, internal rotation, and external rotation. We'll do the same thing on the other side. Flexion, extension, abduction, and adduction, internal rotation, and external rotation. We're going to go ahead and do the same thing with the knees. Flexion, internal rotation, external rotation, and extension. Making sure none of the joints are hyperextending. Flexion, extension, internal rotation, and external rotation. Perfect. We're going to move on to the ankles. So I'm going to have the patient dorsiflex the foot and plantar flex. And I'm going to test the muscle strength at the same time. So go ahead and pull your toes up against my hands and push them down to the floor against my hands. Perfect. So while assessing the patient's range of motion, I'm also assessing the peripheral vascular system, assessing the legs for the size, symmetry, any swelling, any venous pattern, such as varicose veins, noting the skin color, the temperature, any hair loss. So I'm going to go ahead and palpate the lower extremities, checking the popliteal pulse with both hands. The dorsalis pedis pulse, and the posterior tibial pulse. And I'm going to go ahead and check the brachial, and the radial, and they're all 2+ bilaterally. So I'm going to have you go ahead and sit up. We're going to go ahead and continue with our range of motion of the shoulders. You bring your shoulders out, abduction, across, adducting, perfect. And then we're going to put them behind your head, external rotation, and then behind your back, looking at internal rotation. Perfect. So we're going to go ahead and test range of motion of the elbows. We're going to go ahead and put them straight out. Perfect. Then we're going to test muscle strength at the same time, so if you'll pull them towards you. Yeah, just like that. Perfect. And go ahead and extend your arms. We're going to look at the wrists. You can pronate and supinate them. Perfect. And then we're going to do it quickly. Perfect. And that's testing for cerebral function with rapid movement at the same time. We're going to look at the fingers and the knuckles. Perfect. Swallow at our hands. I'm going to go ahead and test our grip strength. So you're just going to grab my fingers. Looking for any kind of muscle weakness, just squeeze them as hard as you can. Perfect. Not noting any signs of atrophy. We're going to go ahead and open your hand. And we're going to do neurosensory checks. Once again, just checking the cerebral function. We're going to do number identification first. And you're just going to tell me what number I'm drawing in your hand.
2.
Perfect. Keep your eyes closed. I'm going to place an object in your hand now. And close it. And tell me what that is.
Cotton ball.
Perfect. You can open your eyes. That's strychnosis. Once again, checking the cerebral function. So now we're going to do point to point. Have you open your hands just like that and close your eyes. So whatever finger I touch, if you'll touch your nose with it. One more. Perfect. You can open your eyes. We're going to do point to point of the lower extremities now. You can run your heel up and down your shin on each side. Perfect. And while assessing this, I'm assessing the hair distribution, looking for any varicose veins, making sure color looks good. And while we're here at the toes, we're going to test proprioception. So if you can look forward for me, I'm going to move your toe. Tell me which way I'm moving it.
Up. Down.
Perfect. We're going to go ahead and test the patient's reflexes. So I'm going to start with that tricep. Just relax your arm. And then the bicep. And I'm going to go to the other side. The tricep, relax. And then the bicep. I'm going to do the brachioradialis. On the other side. And the patellar. Oh, I'll lift this up. And the Achilles. I'm going to have you stand up. We're going to test for ataxia. I'm going to have you close your eyes. Perfect. And you can open them. And that's a Romberg test. I'm making sure she's not going to lose her balance. If you can bend over and touch your toes as much as possible for me. Perfect. So right now, I'm going to check the patient's spine, making sure it's nice and midline. There's no curvature, such as in scoliosis. Checking the SI joints while I'm here, making sure there's no tenderness. If you can go halfway up now. We're doing the same thing, making sure that the spine is nice and midline. No tenderness. Perfect. You can stand up all the way. Next, we're going to test the patient's gait. I'm going to have you start right here and just tandem walk that way. So just heel to toe. Perfect. Looking at the muscular control and strength. Perfect. And if you go back on your toes, then your heels. Perfect. You can sit down. We're going to go ahead and go over the genital and for exam for the men and women. So for a man, I'd ask him to lay on his left side in the lateral recumbent position for the rectal examination. I'd first start by inspecting the sacrococcygeal and perianal areas, palpating the anal canal for any lesions, masses, or skin breakdown. To perform a digital rectal examination, I would first assess the sphincter for tone and palpate the anal canal and the surface, rotating my hand to palpate as much as possible on the patient's right side, and then the other way on the patient's clockwise to palpate the posterior side on the patient's left side, feeling for any masses, tenderness, nodules, or any irregularities. For the prostate exam, I rotate my hand further counterclockwise to palpate the prostate gland, sweeping my fingers over the prostate gland to identify the lateral lobes and the median sulcus, noting the size, shape, mobility, and consistency of the prostate. And I'd identify if there are any nodules or any tenderness. I would then examine the penis and scrotal contents, checking for any hernias. Next, I would assess the skin of the penis, the foreskin, and the glands for any ulcers, scars, nodules, and inflammation. Next, I'd palpate the shaft of the penis for any abnormalities, noting any indurations or tenderness. Next, I'd inspect the scrotum, including the skin by lifting it up, to inspect the posterior surface, noting any lesions or scars. I'd be inspecting the hair distribution and scrotal contours for swelling, lumps, or bulging masses. Next, I would palpate each testy, including the epididymis and the spermatic cord for presence, size, shape, symmetry, any tenderness or masses. So for a woman's genitalia examination, I'd make sure she's emptied her bladder completely prior to the exam. I'd make sure she's draped from the mid-abdomen to the knees, and I'd assist her into the lithotomy position. I'd make sure I have the appropriate size speculum for the patient. First, I'd inspect the external genitalia, inspecting the mons pubis, the labia, and the perineum for any inflammation, ulcers, any discharge, swelling, or any lesions. Next would be the internal examination. I'd let the patient know I'm about to insert the speculum and applying downward pressure. I would separate the labia minora and introduce the closed speculum. I would then remove my fingers from the introitus and rotate the specular into a horizontal position and maintain pressure until it's inserted into its full length. I then slowly open the speculum to visualize the cervix, noting the position, the color, or any characteristics. I'd inspect the cervical os for discharge, ulcerations, nodules, any masses or bleeding. To obtain a pap smear, depending on the speculum, the collection tool, either the cervical broom, the cervical scraper, or endocervical brush, I'd insert it gently into the cervical os and rotate it, and then carefully remove it. To withdraw the speculum, I'd slowly pull it out while also inspecting the vaginal walls for any masses, lesions, or any abnormal discharge or bleeding. As the speculum is clearing the cervix, I would loosen the thumb screw and maintain the thumb screw with my thumb. After the pelvic and pap smear exam, I'd obtain consent to perform the rectal exam while the woman is in the lithotomy position. I'd use the same techniques as the male rectum exam, and in this position, it would allow me to do a bimanual examination to inspect for a pelvic mass or palpate cancer high in the rectum. So to summarize my findings, the patient is of average height and weight for her body structure. She is animated and responds quickly to questions. She's alert and cooperative. Her thought processes are coherent and insight is good. She's oriented to person, place, and time. Her color is good. She lies flat without discomfort. Her capillary refill was less than 3 seconds. Palms are warm and dry with good color. Her nails are without clubbing or cyanosis. Hair of average texture and well groomed. Scalp is without lesions and normocephalic. Her vision was 20/20 bilaterally. Visual fields full by confrontation. The conjunctiva was pink, the sclera white. Pupils were 4 millimeters, constricting to 2 millimeters. Round, regular, equally reactive to light. Extraocular movement was intact. Ears and pearly gray and translucent in the tympanic membrane. A serum partially obstructing the right tympanic membrane. The cone of light was measured at 5 in the right ear, and the left ear canal was clear. Tympanic membrane was pearly gray and translucent, with good cone of light at 7. Acuity was good to whispered voice. Weber was midline, and air conduction was greater than bone conduction bilaterally. The nasal mucosa is pink. The septum is midline. No tenderness noted. Oral mucosa pink. Dentition was good. Tongue is midline. Tonsils absent, and pharynx is without exudate. The neck is supple. Trachea is midline. The thyroid was non-palpable. No CVA tenderness was noted. No cervical or axillary nodes noted. The thorax is symmetric with good exertion. The lungs were resonant on percussion. Breath sounds were clear and equal on auscultation. Regular venous pressure was 3 centimeters above the sternal angle, with the head of the bed raised to 30 degrees. The carotid upstrokes were brisk without bruits. The apical impulse was discrete and tapping barely palpable in the left fifth intercostal space. Good S1 and S2. No murmurs were noted. The abdomen is concave. No scars noted. Bowel sounds were normoactive in all quadrants. The liver span is 7 centimeters in the right midclavicular line. The edge was smooth. The spleen was non-palpable. The extremities are warm and without edema. No edema was noted in the ankles. No varicose veins noted in the lower extremities. All pulses were 2+ and equal. No joint deformities or swelling on inspection or palpation. Good range of motion in the hands, the wrists, the elbows, shoulders, spine, hips, knees, and ankles. All cranial nerves are intact. Good muscle tone. Strength is equal bilaterally in the neck, biceps, triceps, hand grips, and tibialis anterior. The rapid alternating movement and point-to-point movement are intact. Her gait is stable. Sensory vibration and sternocys are intact. Bromberg is negative. Reflexes were 2+ in the biceps, triceps, brachioradialis, patellar, and the Achilles. And that is the end of our head-to-toe assessment today. Thank you.